حطيت في عجله.
Hello.
Technical team, are we live? Hello.
Yes, sir. We are streaming live, sir.
Yeah, technical team, please go live and please confirm once it is live so
We
that
are
we can
live,
start.
sir. We are live. We can start, sir.
Okay, we are live. Okay. So good afternoon to all the attended doctors. Today with us we do have Dr. Swapnil Giri sir. Swapnil Giri sir is particularly MBBS DNP Pediatrics and sir is director of Swas Critical Hospital, which is at Narayan Nagar, Hingoli. So sir is going to take us through the topic of productive cup in pediatric. So if in between any attended doctors is having any query post presentation, they can ask to sir. So just a second, let me share the screen. Sir, we can start, sir. Giri, sir.
Yes. Good afternoon, everybody. So I'll just highlight some points regarding productive cough in pediatric practice, common pediatric practice. Next slide. So we'll go by what are the causes of cough, what is the common etiology for cough, how to diagnose different types of cough, treatment algorithm for cough, and the treatment of productive cough in general, and some take-home points. Next slide. So cough is also like a it's a tussle of is a uh, involuntary act that clears the throat and breathing passes of foreign particles and microbes and irritants and mucus. It is the most common symptoms in our pediatric practice. So depending on duration of cough, it is divided into acute, subacute, and chronic cough. So if it is less than 3 weeks, it is acute cough. If it is more than 3 to 8 weeks, it is a subacute cough. And when it persists for more than 8 weeks, it is called as a persistent cough. And depending on sputum, it is either a productive cough or a non-productive cough. So mostly the coughs are like dry cough. They have no or minimal sputum. And 20% of the productive cough have thick and viscous mucus with difficulty in expectoration. And 60% of the productive cough have with no difficulty in expectoration. Next slide. So it is a basically cough reflex. There is a presence of cough reflex which is responsible for the cough. Whenever there is a stimulus in the airway, it sends signals to our brain, and then through a signal when brain react to this irritant, and it results in the contraction of respiratory muscle responsible for the cough. So slightly this is the pathway for the cough reflex. Next slide. So most common causes for acute cough are like viral URTIs, which we commonly see in OPD, then acute bronchitis, post-nasal drips, some bacterial sinusitis, then acute exacerbation of asthma, exposure to irritants, and subacute causes are like post-infectious cough, tuberculosis, then upper airway cough syndromes, asthma, GRD, bronchiectasis, and bronchitis. In the chronic causes of the cough, some which is a rare in pediatric age group, like tumors of the lung, GRD, drug-induced cough, cardiac diseases, and chronic idiopathic or refractory cough. So next slide. So when we should worry in the cough? So when there is a presence of cyanosis or hypoxia on pulse oximetry, there is stridor, there is respiratory distress, there is toxic appearance and abnormal lung examination, then we should worry about the cough and we should have prompt treatment for the same. Next slide. So what are the diagnostic steps for the cough? Routinely for acute cough, not much much of examination. This diagnostic tests are required, but in acute and subacute and chronic cough, we need a examination. Like pulse oximetry and chest X-ray should be done in patient with red flag findings, like we mentioned in the previous slide. Then chest X-ray, sputum culture sensitivity, pulmonary function test, then bronchial challenge test, then time and clinical setting of onset, then what are the exaggerating factors and associated symptoms like presence of mostly after eating some cold things or exposure in cloudy atmosphere. Then if there is a prior history of atopic disease, which can cause asthma and reactive airway disease in children. Then medical drug exposure history in the person as well as family. So what are the medications has been tried? That also we need to ask. Next slide. So what are the treatment for cough? Non-pharmacological treatment like lifestyle modification, like avoidance of cold and oily substances, as well oily food, as well as some gargling with the salt water. And the pharmacological treatments are like uh, peripheral acting and central acting, cough expectorant, which are mucolytic, bronchiolitis, and mucokinetics and secretive enhancement, like leosalbutamol, ambroxol, terbutaline, and in antitussive, there are some centrally acting as well as some peripheral acting. Peripheral acting is leotropazine, and centrally acting are like non-narcotic like dextromethorphan and narcotics like codeine, which are rarely used. And some adjuvant use of antitussives like antihistamines like chlorpheniramine, diphenhydramine, promethazine, and belastin. Next. So when there are two types of cough, as we discussed, there is a dry cough and wet cough. So approach to both cough are different. Like for wet cough, when we treat with expectorantus and mucolytic, if it is resolved, it's fine. If it is unresolved, we need to do some sputum examination, sputum culture, and according to the culture center, we need to treat with the appropriate antibiotic. If it is still unresolved, then we need to look for the underlying disease such as bronchitis, bronchiolitis, bronchitis. And if it is resolved, then it's fine. We need to continue the antibiotic therapy. And in dry cough, we have antitussive and demulcents. If it is resolved with that, that's fine. If it is not unresolved, we need to check for irritants and allergy. 4 to 8 weeks of trial with inhaled corticosteroids can be given as a supportive treatment. If it is resolved, that's fine. If it is not still not resolving, then we need to look for the underlying other causes of dry cough. Next slide. So there are mucoactive drugs like mucolytic, mucokinetic, and expectorants. Next. So there are different kinds of mucoactive drugs like ambroxol, bromhexine, then carbocystine, N-acetylcysteine, endorphin, and sorbitol. So these are the different mechanism of action, and uh, the antibiotic with what are the reactions with the antibiotics. So ambroxol, bromhexine, sorbitol, that there is increased level of drug level with the use of antibiotics. And the efficacy wise, these are mostly they are safe in pediatric practice. Next slide. So guanfacine has a well-established and favorable safety tolerability profiles in adult as well as pediatric doses. So dose range from 2000 to 4000 mg 4 hourly and up to 6 times a day. It allows there is a flexible dose schedule for this drug to allow the increased plasma concentration. Then they need a multiple daily doses to maintain the 24 hours drug level. Then extended release of guanfacine tablet formulation are available and providing convenience for with 12-hourly dosing also. And their and portability compared to the liquids. Next slide. Hmm? So these are the some placebo control randomized control trial with gonfencin, where there is all the studies are significant level with the p-value less than 0.05. Next slide. So triple combination of levosalbutamol, ambroxol, and gonfencin was found to be safe and efficacious, as we have all these studies have shown that. Next slide. Demulcents. So demulcents consist of honey, longes, linctus contain syrup, and menthol. They increase the swallowing and saliva production and interfere with the cough reflex or coat peripheral sensory receptor responsible for triggering the cough. Cough receptor irritation in the pharynx is also reduced with the demulcents. Next slide. Bronchodilators. So most of the bronchodilators like they responsible there are very few side effects associated with bronchodilators like tremors, palpitations, and vomiting. So these side effects are very mild, and they do not require to discontinue the medication, and we can safely continue the therapy in pediatric population. Next slide. Terbutaline containing cough formulations was efficacious and safe for treatment of productive cough, and it has also very less side effects. Next slide. Next slide. Next slide. Next slide. Next slide. So the slides are not coming. I'll just read it. Antibiotic use in acute cough. So patient with acute cough may be at higher risk of complication if they have pre-existing comorbidities such as significant heart, lung, renal, liver, or neuromuscular disease, or immunosuppression or cystic fibrosis. And young children who are born prematurely also have increased tendency of morbidity associated with the cough, acute cough. So what is the antibiotic therapy recommendations in acute cough? Usually the upper respiratory infections and not systemically very unwell or stable child, we don't require any antibiotic therapy. Acute bronchitis and not systemically very unwell or without any risk of complication, also we don't require any antibiotic. High risk of complications like face-to-face examinations such as which requires immediate antibiotic uses with antibiotic backup antibiotic prescriptions. Systemically very unwell child offer immediate antibiotic uses. So advise usual course of acute cough 3 to 4, managing symptoms with self-care. When seek a medical, for example, if symptoms worsen rapidly or significantly, do not improve with 3 to 4 weeks of treatment, or person becomes systemically very unwell. Antibiotic are not prescribed. Advice, why not? With an antibiotic advice on possible adverse effect include diarrhea. With backup prescription advice using if symptoms worsen rapidly or over the times. Here do not offer a mucolytic or an oral inhaled bronchitis or an oral inhaled corticosteroid unless otherwise indicated. Recess the symptoms if it's alternative diagnosis such as pneumonia, any symptoms or signs suggesting of more serious illness or conditions such as cardiorespiratory failure or sepsis or previous antibiotic use, which may have led to the resistance antibiotic bacteria. So in that case, refer to the hospital, seek a specialist advice and for further investigation and management. If person has symptoms, signs suggesting of more serious illness or condition, for example, sepsis or pulmonary embolism or lung cancer. So that is the flowchart for management of acute cough. So common cause of cough like URTI, LRTI, acute exacerbation of COPD, asthma, or pneumonia pertussis. So regarding this, so we can avoid antibiotics in first two cases, and in second COPD and pneumonia, we need a proper antibiotic coverage with plus or minus corticosteroids. In acute cough, 7 to 10 days. Productive cough, mucoactive drugs, like mucolytic, mucoanalytic, and expectoration can be given. Acute dry cough and non-opioid anti-tissue, antihistamines deconsistence, if necessary, can be given. After assessing all the type of cough, sound, intensity, frequency, medical and drug history, and associate physical examination. So if any life red flag signs are there, then we need to like rule out the life-threatening pneumonia, exacerbation of asthma or COPD, pulmonary embolism, heart failure. So we need to refer this patient to the higher center. In case of subacute cough, post-infectious, if it is post-infectious, we may need to manage it symptomatically. If it is a upper airway cough, first generation antihistaminic or oral decongestant or nasal epinephrine can be given. Asthma, COPD, avoid trigger and follow the GNR guidelines or gold guidelines. And TB pertussis, we need to give the proper antibiotic course. In environmental exposure associated cough, we need to avoid the exposure. So in case of management of chronic cough, we need to have a history, physical examination, medical history. We need to have X-ray, spirometry, CBC, additional investigations if required, and then clinical, depending on the clinical and condition of the baby, we need to further assess the child. The common causes of chronic cough like upper airway syndromes, we can give intranasal corticosteroid and antihistaminics. In GRD, proton pump inhibitors can be given. In asthma, COPD, bronchodilators can be given, or in inhaled corticosteroids can be also given. In non-asthmatic eosinophilic bronchitis, inhaled corticosteroids as well as LRTA can be given. In case of red flag signs, cough, symptoms, stress, intolerance, we need to refer this patient to the appropriate higher center. In unexplained cough, codeine can be given when the other treatment fails. Codeine is usually reserved drugs, and other cough suppression therapy can be also given, such as gabapentin also. In chronic refractory cough, morphine, gabapentin, or amitriptyline can be also given. So take home message is that cough is the most second common symptoms in primary care practice in India. Routine diagnostic studies are unnecessarily unless the red flags for cough are present. Symptomatic treatment without antibiotics should be started for acute and subacute cough. Antibiotics are recommended for 5 to 10 days for productive cough when purulent symptoms is there, or in subacute cough due to bacterial infection. Okay. Thank you.
Yes. So with question of that, which one is it? According about the prevalence of the dry and productive of implementation in our
Hello,
data.
sir.
Sir, एक question है. According to you, how is the prevalence of dry and productive of pediatric patient in our territory?
So in pediatric patient, usually they are not able to expectorate the sputum. So mostly the 90% of the cough in pediatric population are productive cough, less than 2 years. However, in elderly children, school going age, the mostly the dry coughs are there. So in case of infants and children less than 2 years, we need to consider it as a mostly wet cough only. And then in elderly children, we can have incidence of dry cough also.
Sir, one more question. That is, which are the antibiotics that you usually prefer in treating cough?
So in case of cough with upper respiratory tract infection or lower respiratory tract infection, in case of lower respiratory tract infection, we can have amoxiclav, amoxicillin clavulanic acid combination, and or azithromycin. In case of URTI, also upper respiratory tract infection, also we can consider as amoxicillin clavulanic acid or azithromycin as antibiotic therapy.
ठीक है सर. थोड़ा लॉग इन होते शकता का सर आदर्श.
Yes.
Okay,
Sir, on behalf of entire Glenmark family, sir, I would like to say, thanks to you, sir. From your busy schedule, sir, so today you have given us a time for this academic initiative, sir. Thank you so much, sir. Technical team, are you there? Technical team?
Thank you. Thank you.
Okay, sir. 4 वाजेपर्यंत.
Technical team, are you there? Technical team?
Hello, sir.
Technical team means sir has just finished with his presentation, but I
Okay.
request you to close this meeting at 4 p.m. so that our 1 hour will get done.
Okay. So what we can do, sir? Is it okay if I make you the host and you can end it from your side? Is it fine?
Okay, please take me host so that I can end.
Done. I have made you the host. Thank you.